Sabay-sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, natin adhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH. May busilak ng utak at puso, kailan ba'y di nagkulang sa talino at
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary health care in the era of universal health care. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Good afternoon to everyone on Zoom and those watching the Facebook and UP Manila live streams. Before we proceed, let me introduce myself as your moderator today. I am Dr. Christine Denise Corvera de los Reyes, a fellow of the Philippine College of Endocrinology, Diabetes, and Metabolism. I am a practicing endocrinologist at the Asian Hospital and Medical Center and a proud member of this year's Silver Jubilarians, the UPCM class of 1998. Allow me to introduce our esteemed guest speaker for today, Dr. Michael Joseph Agbayani. He is a clinical associate professor at the UP College of Medicine, the head of the Central ECG Station at the Philippine General Hospital, council chair of the Philippine Heart Association, part of the Council of Electrophysiology and Pacing, and secretary of the Philippine Heart Rhythm Society. Dr. Agbayani is also from the UP College of Medicine class of 2003. Today, he will talk about amiodarone in the management of ventricular arrhythmias. Thank you for taking time out to join us today. Dr. Agbayani, you have the floor.
Thank you for the introduction, Dr. De Los Reyes. I'll share my screen. Okay, can everyone see my screen now? Hello?
Yes, we can.
Sorry, not sure if I'm sharing the correct screen.
Yes, you can see it clearly, Dr. Agbayani.
Can you see my presenter view or just the slide?
The slides. We see the
Just
slides.
the slides. Okay, good. Thank you. Thank you. Good morning, everyone. Sorry for the technical issues. I'm here to talk about amiodarone in the management of ventricular arrhythmias, particularly ventricular tachycardia and ventricular fibrillation. Okay? And then here are my disclosures. And let's start with a case. So this was my patient pre-COVID. Okay, so 56 years old with risk factors for coronary artery disease, such as smoking. The patient was also hypertensive, and he already had a myocardial infarction 2 years ago. and is on and off with his medications. I'm sure you've managed patients like this before. It's usually because of financial issues, and of course issues when it comes to uh, hearing about things in social media na, "Dok, pagka uminom kasi ako ng ganito, sabi nila masisira yung kidneys ko." Okay, so this is something that we actually talked about after his admission. And so he had a heart attack 2 years ago, symptoms of heart failure, shortness of breath, and orthopnea. And then he reported palpitations a few weeks before his admission, and then he lost consciousness while working in his garden. Okay. So during the admission for ST elevation MI 2 years ago, the patient already had episodes of ventricular tachycardia. So he had recurrent ventricular tachycardia. Unfortunately, these were not like very well documented, as sometimes happens when it comes to mga arrhythmias. So, but I saw dun sa kanyang records that he was treated with IV amiodarone with great success. Actually, his was arrhythmia free during his stay in the ICU. He underwent PCI of 2 vessels and was discharged well. However, he had to be on anti-ischemic meds, obviously, and heart failure medications. And his ejection fraction at the time was 42%. And they decided against implanting an implantable cardioverter defibrillator, which is a device that we put in to monitor a person's heart when they're at risk for ventricular arrhythmias. So it's basically a bigger pacemaker. So it's like a pacemaker. It monitors your heart. The difference between an ICD or an implantable cardioverter defibrillator and a pacemaker is that your defibrillator ICD can shock you out of ventricular tachycardia. Okay, so they decided against, maybe because the ventricular tachycardia they thought was due to the due to the ST elevation myocardial infarction, which happened 2 years ago. So treatment with amiodarone at that time was pretty much in keeping with uh, keeping with the guidelines of the treatment of VT during an acute coronary. So it has a class 2A indication. Remember that beta blockers are still the antiarrhythmic of choice, but if VT and VF are resistant to beta blockade, you still have episodes of ventricular tachycardia, you should consider amiodarone intravenous, which a class 2A indication, or lidocaine class 2B indication. Okay, it's also very important to give this drug very early because in patients with ST elevation MI with multiple episodes of ventricular tachycardia, ventricular fibrillation, you get more benefit if you give it early. Looking at the patients in the GUSTO trial, which is a trial of antithrombotics, which included patients in the acute phase of the ST elevation MI, they found that within the first 3 hours, more patients survived in patients with amiodarone versus those who did not receive the drug. So for this particular admission, as I said, he presented with loss of consciousness. Good thing his family members knew CPR. Started CPR early, loaded him into the car. The nearest hospital was actually pretty close. In the emergency room, okay, this was not the rhythm during the first encounter, but this was an ECG taken in one of the episodes of ventricular tachycardia. So this is ventricular tachycardia. It's a regular wide KRS tachycardia, and it can be, you can actually be very stable if you have VT, but most of the time you're unstable. You have shortness of breath, hypotension. And in this case, the patient was pulseless, so ACLS was started. So if you look at the 2020 American Heart Association BLS ACLS guidelines, you can see if you have VT or VF and it's pulseless, you start CPR immediately. And then if the rhythm is shockable, VT or VF, you try to shock the patient out of it. But if it's refractory, you can give a amiodarone. Okay, so let's look at this closer. So you can give amiodarone or lidocaine. Okay, so CPR every 2 minutes, and then you try amiodarone, and these are the doses. Okay, so in the ACS guidelines, the amiodarone is used for ventricular tachycardia and ventricular fibrillation arrest. And if unstable, you try to shock the patient out of it. If stable, you have time to think about it. And if the patient has structural heart disease, then amiodarone is actually the better choice. So amiodarone is a non-selective potassium channel blocker. It's one of the most powerful anti-arrhythmics available in the Philippines. In fact, I think it's overused. So sometimes konting PVC lang some of our physicians give amiodarone. And I think we should remember that these are very useful in life-threatening. The amiodarone is very useful in life-threatening arrhythmias. So we have ventricular tachycardia that's idiopathic, meaning the patient never had an MI, heart is normal, structurally normal when you look at the 2D echo. And then there are some PVC sometimes, or runs of non-sustained ventricular tachycardia or sustained ventricular tachycardia. We call this an idiopathic ventricular tachycardia. And amiodarone is not the first line for this. You should not give this as the first line medication. But for ischemic heart disease, for dilated cardiomyopathy with ventricular arrhythmias, it's actually very useful. And it's also used in atrial fibrillation. Sometimes it's used for supraventricular tachycardia, but it's actually not the best. It's not indicated as a class 1 drug. Okay, so we usually give beta blockers first or calcium channel blockers first. But for ventricular arrhythmias, it's very useful. Okay, so the patient survived this particular episode, and then his ejection fraction at the time of this was 24%. And because he had repeated episodes of ventricular tachycardia, we decided to put him on cardiac resynchronization therapy. So he had a CRT ICD. So this is the special kind of ICD. So it can monitor your heart, it can shock you out of ventricular tachycardia, but it also tries to synchronize the electrical system of your heart. And this is a very good treatment for heart failure with reduced ejection fraction. So his EF was less than 35%. Beta blocker dose was were adjusted. For some reason, did not really consider starting amiodarone oral. Okay? And this is not his fluoro, but this is a representative fluoro picture of a patient who has an CRTD. So this is the pulse generator, and you have leads into your right atrium, your left ventricle, and your right ventricle. So the thick part here, those are shock coils. So when the patient needs to be shocked out of a ventricular tachycardia, that device can do it. Okay. So his heart failure status improved in the sense that he had less like shortness of breath, less orthopnea, but unfortunately, when you get better and your ejection fraction stays below 35%, you're still at risk for sudden cardiac death. In fact, more people in class 2 and 3 heart failure, meaning functional class 2 and 3, patients who have symptoms and moderate to heavy exertion, but asymptomatic with mild exertion and at rest. These are the patients who are doing better clinically, but they're the ones who are at higher risk for sudden cardiac death as compared to patients with class 4, meaning shortness of breath during at rest. These patients actually die more from heart failure than sudden cardiac death. So episodes of syncope, again, after adjustment of medications, multiple episodes did not sound like episodes of vasovagal syncope, change in position. It happened suddenly and was precipitated by palpitations. And this time the patient also reported to feel ICD shocks. So most patients report ICD shocks as feeling like they've been kicked in the chest. Okay, so this is a very, very painful experience. And this is a representative interrogation report of your ICD. And you can see here is the ventricular arrhythmia. Okay, so the ventricular arrhythmia was detected, and then this represents the ICD shocking the patient out of the rhythm, and this is now sinus rhythm. Okay, so a patient was the shocks were successful. The patient survived the ventricular tachycardia episodes because the ICD was there, but he had episodes of repeated ventricular tachycardia. Thus, he was brought to the emergency room, and then repeated shocks were delivered by the device during that time. And then the patient repeatedly lost consciousness, and the attending decided to attach an external defibrillator and to put a magnet, okay, so an ICD magnet or a pacemaker magnet. What that does is it doesn't turn off it, contrary to popular belief, it doesn't turn off if it's put on a pacemaker, it does not turn off the pacemaker. It only goes into asynchronous mode. If it's an ICD, it will turn off the detection, meaning it will ignore ventricular tachycardias. Okay, so the reason why the attending decided to do this is to save battery. So since the patient was already in the hospital, you can actually attach an external defibrillator, put him in the ICU, and every time he had the ventricular tachycardia, the staff or the resident on duty or the fellow on duty will shock the patient out of ventricular tachycardia, and this will save battery life of the ICD. Okay, and then the patient was put on an antiarrhythmic drip, and then electrolyte abnormalities were corrected. Okay, so the patient was given amiodarone intravenously. So we call this when you get ventricular tachycardia repeatedly in 24 hours, or an ICD shock repeatedly in 24 hours. We call it an electrical storm. Okay, so this condition occurs in about 10 to 20% of ICD recipients, and it varies. The definition varies depending on on which textbook you read. But I think we've already decided that it's 3 or more sustained ventricular tachycardia or ventricular fibrillation episodes or ICD shocks which were appropriate within 24 hours. We call that an electrical storm already. So when you have a patient with an ICD or a patient with heart failure, when they have episodes of ventricular tachycardia, 3 or more, they're already an electrical storm. And the reason for this is when you have dilated cardiomyopathy or ischemic cardiomyopathy, you get scar tissue, okay? And then that uh, gives the electrical system of the heart a chance to short circuit. Okay, so they have re-entry. Okay, so the electrical signal forms a re-entry circuit within the scar tissue. Okay, and that's what causes the ventricular tachycardia, which is usually a monomorphic ventricular tachycardia like our patients. Okay, so patients with electrical storm, with structural heart disease, okay, antiarrhythmic therapy with beta blockers, okay, so non-selective preferred, in combination with intravenous amiodarone. Okay, and you can see here if you have high ventricular arrhythmia burden, you reprogram your ICD, you do beta blockade and sedation, and you give intravenous amiodarone. Okay, so that's the treatment for ventricular tachycardia, which are repeated shocks or electrical storm. And again, here you can see if you have a hemodynamically stable patient, you check your ICD shocks. But if you have a hemodynamically unstable patient, you have to go with ACS, BLS kagad. You do your beta blockade, you address potential triggers, electrolyte abnormalities, and acid-base abnormalities are sometimes missed. So this is something that you have to look at. It's not always just ischemia. In fact, for these particular patients, most of the time, by my experience, it's not really ischemia by this time. After a remote heart attack 2 years ago, usually it's scar tissue, okay, and some kind of an electrolyte imbalance or acid-base imbalance. Of course, you have to rule out ischemia, but I think most of the time it's not ischemia, okay? Especially if it's monomorphic ventricular tachycardia. So here are the treatments for electrical storm or ventricular tachycardia storm. And antiarrhythmic drugs is a good option. Of course, the patient will be on an ICD already, and you might do ICD reprogramming, so the patient does not receive a lot of shocks. Okay, there's a way of reprogramming your device so that they don't receive shocks. For patients who are very have a high burden of ventricular tachycardia, you do sedation, autonomic modulation, and PGH actually can do ventricular tachycardia ablation already. So for some patients, especially once we calm the electrical storm down, we actually bring them in for ablation. Okay, so what we do is, I'll go back to the scar, is we look for this, the isthmus, and then we apply radiofrequency energy to basically burn that area. Okay, so it doesn't do re-entry anymore. Okay, so that's what we do in the electrophysiology lab. Okay, so there have been numerous studies for patients who have ventricular tachycardia. And this is one study where they were actually looking for the optimal dose for amiodarone. And you can see the higher the dose, the lower the the chances of you having recurrent ventricular tachyarrhythmias or ventricular arrhythmias during your admission. Okay, and the OPTIC trial looked at 400 plus ICD patients, and patients were randomized to treatment for 1 year with amiodarone plus a beta blocker alone, or sotalol. Okay, and they saw that patients did the best on amiodarone plus beta blocker, so there are less shocks for these ICD patients. So they had less ventricular tachycardia burden if you put the patient on amiodarone plus beta blocker. Okay, so you can see less multiple shocks in this arm of the study of OPTIC. Okay, the problem with amiodarone, which we'll be talking about later also, there's just a lot of extra cardiac um, side effects. Okay, I'm sure you're all familiar. So there was a significant increase in adverse pulmonary events and a significant increase in hypothyroidism. Okay, interesting. One thing about antiarrhythmic is we're very, very concerned about proarrhythmia. In OPTIC, there are actually no episodes of torsade de pointe. So amiodarone induced or sotalol induced torsade de pointe were actually actually in OPTIC there were none. Okay, but these are actually very rare. So outpatient management of ventricular arrhythmias in ICDs, if you have a patient who has multiple shocks, you have to consider the addition of oral amiodarone or a replacement of the beta blocker to sotalol. So sotalol is sort of available. You have to get it from another hospital, so it's not available in most hospitals here. How about patients so not our patients, so patients who can't have the ICD, who refuse an ICD, or are not amenable or have contraindications to ICD treatment? And usually, which cases are these? Usually, these are patients with functional class 4 heart failure who have very, very low life expectancy, like less than 1 year, because the ICD guidelines say that you have to have a very long life expectancy relatively if you're going to put in an ICD. So, for example, you have a patient with heart failure and then an end-stage cancer, then usually we don't put in ICDs anymore. Okay, and you see here patients. They did the meta-analysis in patients with or without They included patient studies not in patients who are high risk for ventricular arrhythmias who didn't have ICDs or already had ICDs before the study. But the ICDs had to be in both arms of the study. So they were not looking at the effect of the ICD per se. They were looking at the effect of amiodarone. And there was a decrease in sudden cardiac death in the pooled results, in the cardiovascular death. But there was no significant change in all-cause mortality, which is what we see in the ICD trials. There was an increase in all-cause. There was a decrease in all-cause mortality, which is why we say that ICD is still um, better than just antiarrhythmic medications. Okay, so that's the management of ventricular tachycardia storm or electrical storm. These will happen, as I said, 10 to 20% of ICD patients, but the prognosis is very bad, so you really have to be on top of these patients. And so this is a picture of us doing a ventricular tachycardia ablation when I was training in Singapore. Okay? And so we have the capability of doing this in PGH already. Okay, so if you have a patient who has repeated ventricular tachycardia, we can do ablation if they are whether they have they don't want to take their antiarrhythmic medications anymore, or they have contraindications to other antiarrhythmic medications. Okay, if you have a patient who has multiple ICD shocks like our patient, you have to check whether they were really shocks. We call them phantom shocks if the patient felt something, but when we do the interrogation of the device, there's actually no shock. So sometimes some patients have this, especially those who have been shocked before. It's a form of or part of their PTSD when they have these particular episodes. Masakit, it's a very painful experience. So sometimes they have phantom shocks. Inappropriate shocks is when your ICD shocks you because of an SVT or atrial fibrillation, or there's a problem with the lead. Okay, so for us, it was an appropriate shock, so we have to use antiarrhythmics, agent sedation, etc. So these are the particular medications, and you can see amiodarone is actually in a lot of these because amiodarone is a very, very powerful antiarrhythmic. It gets a lot of uh, like a bad uh, especially as electrophysiologists, sometimes we are the ones who discontinue amiodarone. But in appropriate cases, it's a very, very powerful drug. The problem is the extracardiac side effects. Okay, so what do you monitor? So you monitor for pulmonary toxicity. So if you have new onset cough that doesn't go away, or you do your X-rays and your CT scan and you see these findings, you might have to discontinue the drug. In some cases where you can't discontinue the drug, and it's a milder case of pulmonary toxicity, corticosteroids may help, um, and then you just decrease the dose. Okay. Gastrointestinal also is a side effect, but the more common ones that we see is the thyroid dysfunction. So usually it's hypothyroidism, and L-thyroxine can help. Hyperthyroidism is not that as prevalent, but it can sometimes happen. Okay. Skin discoloration, like in this gentleman who has been taking, so some of these are dose related. So he has been taking 400 milligrams per day. So usually that's 200 twice a day. And, he's been taking it for 6 years. So sun exposed areas, you get this bluish discoloration. And then either you discontinue the drug or you lower the dose, and then you tell the patient not to go out too much or to wear sunblock, and then it will actually eventually go away. And pulmonary toxicity is you can have infiltrates in the X-ray and findings in the CT scan, and chronic cough or shortness of breath. So that's something that you have to watch out for. And these are the other side effects. So ocular, this is very common, actually one of the more common ones, although it's reported to be less than 5% for halo vision. Photophobia is visual blurring, and micro deposits are actually very common. So you have to consult with an ophthalmologist and discontinue the drug if it's really, really severe. Uh, Bradycardia and AV block, not that common. You might need to discontinue the drug or do permanent pacing. For our case, the patient already has cardiac resynchronization therapy device, so this is not much of a problem. Um, so how do you monitor? So you test the thyroid function once before treatment and then every 6 months. The problem is in the first 3 months, there will be changes. So your TSH actually will increase, but usually less. It will be less than 20 milliunits per liter. And there will be a transient increase in FT4 and FT3, but more in FT4. And after 3 months, they actually stabilize. Okay, so TSH will reach an equilibrium. It goes back to normal, making it a reliable marker again for thyroid dysfunction. And then T4 remains high normal, while T3 remains about low to low normal. So it's not really recommended to check your thyroid function again within the first 3 months. So usually it's every 6 months. There's no recommendation about when and how often you check for the liver, uh, or to check for ophthalmic, neurologic, and dermatologic evaluations. But I guess will depend on the clinical clinical for symptoms and any change in your patient. And then annual cardiac evaluation plus an ECG. I'm sure this is not a problem because the patients on amiodarone usually are being managed by a cardiologist already. You have annual chest X-ray to check for pulmonary toxicity and respiratory function tests according to clinical manifestations. So if the patient has cough or shortness of breath, you have to check. Okay. So post-discharge, the patient actually did well. So we were able to control the electrical storm with IV amiodarone. The patient was sent home on oral amiodarone and no ICD shock since the treatment. Unfortunately, the patient succumbed to COVID when the pandemic started. It was one of the first few ones that had COVID during the first month of the lockdown, unfortunately. Okay, so in summary, amiodarone is a potent antiarrhythmic and it's very useful for patients who have VT or VFRS, ventricular tachycardia, ventricular fibrillation. For ventricular tachycardia, that's not idiopathic in the sense that it's not the patient because the patient has structural heart disease like a prior MI or a dilated cardiomyopathy. Amiodarone is very, very useful. And in fact, it's the drug of choice if you have structural heart disease. And it's very useful in patients with electrical storm who have repeated episodes within 24 hours of ventricular tachycardia. But we have to be wary of the extracardiac side effects, such as pulmonary toxicity and thyroid disorders. So that's all for now. So I hope there are some questions that I can answer.
Okay, thank you so much, Dr. Agbayani, for that very comprehensive lecture. Okay. As we begin our open forum, we'd like to thank our sponsor for today, Distrifil, for helping make this webinar possible. So let me throw the first question, Dr. Agbayani. You mentioned that during a code, when running a code, ACLS in the hospital, that amiodarone is usually given. Now, my question would be, how soon should it be given? Like, by usually shock and then epinephrine, we say epi 1, epi 2, epi 3. How soon should it be given? Like, should we give it right away, or we wait maybe for a couple of minutes?
So after the first, so in the guidelines, it's after the first shock. So if you do the shock and it doesn't convert, then you resume your CPR and then you give your first dose. That's for the what the ACLS guidelines says. So it's first dose is 300 milligrams bolus, and then the second dose is 150 milligrams. Now it doesn't say whether or not you should keep doing it after the second dose. Personally, I would just run a drip after the second dose if the the second dose isn't successful. So basically, so you do your CPR, and then when you do your rhythm check, you try to shock the patient out. After the first shock, and it's unsuccessful, you give 300 milligrams. You do your cycle again, then you do your rhythm check, and if it's shockable, you shock again. So after the second shock, you give 150. After that, I think the chances of you reverting the patient back to sinus rhythm is a bit low when you're giving. I mean, if you give repeated boluses of amiodarone already. So there are several ways of tackling that problem if the patient's in incessant ventricular fibrillation or ventricular tachycardia. Some patients, some doctors do I forgot what it's called, but it's you put on two defibrillators. Okay, one anteroposterior and one the usual position, and then you shock at the same time. You can basically deliver a higher dose of electricity into your chest. And sometimes these are actually there are studies showing that this is effective in converting your patient from ventricular fibrillation or ventricular tachycardia to um, sinus rhythm. So the longer the code goes, actually the lower your chances of converting them.
Oh, okay. And you, for example, na-revive na, no? So return of circulation, then we just put the patient on the drip. Kasi minsan, there might not be a cardio accessible in some areas or in some circumstances. So
Yeah,
in
yes.
the primary physicians would be the ones to manage. So we just put them on the
Yeah.
amiodarone until when should we?
So there are two things we have to remember. One is I've noticed in several hospitals that I've been in, we have a tendency to underdose the amiodarone. So actually, if you saw the one of the studies that I showed, yung pinaka maganda yung effect niya, the most effective dose within 24 hours, you should be able to load about 1 gram of
Oh,
amiodarone. And we're actually very parang conservative, so some of our trainees will give 600 in 24 hours. And I said, no, that's not enough. So you usually give like a bolus of 150, and
okay.
then you do a 1 milligram per minute drip for about 6 hours. And then after that, you do a zero point 0.5 milligram per minute uh, drip. And then if you have repeated episodes, you give additional boluses of 150. You can give additional boluses. Um, you personally, I keep the intravenous amiodarone on until mga 48 hours na walang ventricular arrhythmias. So if you don't have any sustained ventricular arrhythmias for about 48 hours, that's when I start deciding whether I should stop the IV and put the patient on oral, or especially if corrected na lahat yung abnormalities that we think are causing the ventricular arrhythmias. If you think that it's ischemia, dapat na PCI na yung patient, na percutaneous coronary intervention, um, or na at least na thrombolize na yung patient if you're not in a PCI capable area. So, ang mistake rin na nakikita ko is IV amio and then one cycle lang. Within 24 hours, walang nangyari, they give the oral na kaagad. And I think we have to at least be on 48 hours intravenous without any arrhythmias until we decide to put on oral. It takes some time for the oral loading kasi usually about mga 1 to 2 weeks of mga at least 600 milligrams per day, and that's a very high dose for the oral, before we can lower the dose of the oral amiodarone.
Okay, so we can give it repeatedly as bolus, and we have to hook it right away, because there's a question here of that interval between hooking amiodarone drip after giving the bolus. So bolus, hook right away, and
Yes.
wait for 48 hours without arrhythmias, without
Yeah.
ventricular arrhythmias, until we decide to shift to
Mm.
oral. Yeah. Okay. Yeah. Okay. We have a question on what about for patients, for example, arriving at the ER who are DOA on arrival? The question is, how long do you resuscitate? Do you give, if there's asystole, do you give amiodarone, or pagka hindi
Okay,
shock
so
them, you don't
yeah,
give.
yeah. So non-shockable rhythms like asystole, you don't give. So you only give amiodarone in patients who have ventricular fibrillation or ventricular tachycardia arrests. For asystolic arrest, they're not actually it's not going to be helpful. The same way as shocking a patient with asystole will not revive them. The patient still has to have electrical activity for the antiarrhythmics to work. So amiodarone, you'll only give amiodarone if the patient has a shockable rhythm. I think yung question niya has something to do with when to stop CPR in the
Yes. Yeah.
to stop giving epinephrine. I think there will be a case-to-case basis. If you think it's going to be futile, kasi parang 1 hour na the patient's arrested with no CPR, I don't think it will be helpful. But and then it will depend on siguro the cause. If you think you can still reverse the cause, then you immediately do your CPR and ACLS. For ventricular fibrillation, ventricular tachycardia arrest, the 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 patient will have a higher chance of surviving it if you can defibrillate or cardiovert the patient. Defibrillate the patient kasi usually pulseless na to. Defibrillate the patient within 10 minutes. Okay, so if the patient has to, kaya nga dun sa ACLS, di ba, we have to shock yung pinakamabilis na time to shocking the patient is the best. So parang you start the CPR kaagad, have somebody go get an AED sana. Okay, so this is something that the Philippine Heart Association is working on. Marami tayong automatic external defibrillator in our public places, because if you don't have an AED, parang your chances of surviving a VF-VT arrest is very slim. So yun, yung ano is, you shock first pagka you think it's VF or VTRS.
Yeah, that's correct. Even in clinics, di ba, parang it's important to have these AEDs, no? Kasi it's really life-saving. We'll proceed with the other questions. Here, can metoclopramide be given in those experiencing acute nausea and vomiting with amiodarone? Is there a special precaution for arrhythmic patients? So you mentioned GI side effects of amiodarone.
Yeah.
So in this case,
So
metoclopramide also has
for
some
GI, yeah, for GI side effects, I would just try to lower the dose or take the patient off amiodarone. Remember, amiodarone is very powerful, but it's not the only antiarrhythmic available to us. Beta blockers are still very, very powerful antiarrhythmic, especially in the setting of myocardial infarction or dilated cardiomyopathy. For patients who had really severe symptoms, I would just take the patient off. I had patients na were given metoclopramide for nausea before. It was on amiodarone. I tried to lower the dose of amiodarone and monitor them for any increase in the number of arrhythmias that they have, like premature ventricular contractions and non-sustained ventricular tachycardia. Because even if amiodarone, it's very rare to have amiodarone-associated ventricular tachyarrhythmias. But this is something that you have to watch out for, especially if you're giving other drugs that might interact with amiodarone.
What would these drugs be, Dr. Agbayani?
So
That would
usually
have significant interactions.
it's usually the drugs that we give. We give so if you give beta blockers in the or calcium channel blockers with amiodarone, you have to watch out for bradyarrhythmias. You have to watch out for anything that will prolong the QT interval, like antidepressants, antipsychotics, and some antibiotics. So you monitor the QT interval. So this is very it was very actually a good topic when the pandemic started, because of some of the experimental treatments for COVID were caused some QT prolongation. So we were able to educate if you go to our Facebook page for the Philippine Heart Rhythm Society, we posted our guidelines for how to monitor your QT interval. So you just do your cardiac monitoring in as needed ECG to monitor your QT interval, and you should be fine. It's rare, but it's something that you need to be wary of when you're giving your amiodarone. I think more it's as more worrisome yung pulmonary toxicity and thyroid dysfunction in amiodarone than an amiodarone associated ventricular tachyarrhythmia.
I see. Okay. Question here on, is it helpful if you give amiodarone in patients with MI, ST elevation, but no ventricular arrhythmia? I think this question refers to parang prophylaxis.
Prophylaxis.
Yes.
There's no evidence that it's helpful that we give amiodarone as prophylaxis. So most of the studies of amiodarone are given in patients with structural heart disease that increases the risk for ventricular arrhythmias, plus very frequent ventricular arrhythmias, either in the form of non-sustained ventricular tachycardia or sustained ventricular tachycardia, or frequent premature ventricular contractions. So that the definition of frequent premature ventricular contractions varies from study to study. So usually the the current consensus of what's frequent is if you have more than 20% PVCs among your heartbeats. So if you have more than 20% or the 20% or more PVCs or premature ventricular contractions in 24 hours, then you're at high, that's a high arrhythmia burden, so high frequency. But usually we don't use amiodarone kagad if it's just PVCs.
Okay, so when you say structural heart disease, kanina you mentioned yung may scar tissue. So, for
Yeah, yeah.
example, somebody with a third MI, ganyan, not necessarily having VT or VT at the moment, then
Yeah.
you don't give it right away, not even as
Don't
lapse.
give it right. Yeah.
Okay.
You would definitely give beta blockers first before you start amiodarone.
Okay. The next question would be for new onset of VTAC, wherein it's only a symptom daw of palpitation. Do you know how do you manage that? So walang
Okay.
ECG.
So
Oo.
ventricular tachycardia you have to do your ECG documentation. You have to make sure that it is ventricular tachycardia. So for patients, depends on whether the patient has structural heart disease versus no structural heart disease. So structural heart disease is myocardial infarction, an MI before, or the patient has dilated cardiomyopathy. So non-ischemic cardiomyopathy. If
Mhm.
you work them up, and then if the patient has um, very symptomatic, then you actually start with the usual antiarrhythmics. So for heart failure, definitely beta blockade. So beta blockers. So you give your heart failure beta blockers. You give your anti-ischemic beta blockers, and then you see if the patient has episodes of ventricular tachycardia still. If uh, the patient does not respond to that, then you can start giving the other antiarrhythmics like amiodarone. Or if the patient is doesn't want to take amiodarone for some reason, uh, radiofrequency ablation or ablation therapy is actually very effective in controlling ventricular tachycardia. So for those without structural heart disease, meaning the patient is young, for example, the patient is 25 years old, never had a heart attack before, you do your echo and it's structurally normal, and the patient has ventricular tachycardia, usually these are patients we deem to have idiopathic ventricular tachycardia. And for idiopathic ventricular tachycardia, you don't give uh, the the more toxic antiarrhythmics. You give beta blockade, you give calcium channel blockers, and if they don't respond, you do your ablation. Okay, so and for those with structural heart disease, you might have to put in an implantable cardioverter defibrillator. For those without structural heart disease, ablation is better than putting in an ICD. Okay, so we don't usually put in implantable cardioverter defibrillators in hearts that are structurally normal. Yung electrical problem lang yung problem.
You mentioned earlier, you mentioned that, amiodarone and beta blockers can be given simultaneously. Usually it's beta blocker first, then amiodarone add-on. But in instances wherein it's amiodarone first, then beta blocker add-on, what would be the most appropriate beta blocker to give?
So it depends on the case. So for our case, the patient had heart failure. So the best beta blockers for heart failure would be bisoprolol, metoprolol succinate, or carvedilol. And
Okay.
then sometimes nebivolol. Okay, so those are the four that we give for heart failure. For
Edilol.
ischemic heart disease, you can actually give metoprolol tartrate. But for the acute phase of ventricular tachycardia, you can give an intravenous beta blocker like esmolol. And sometimes it's actually more effective if you give a non-selective. If there's no contraindication to a non-selective, you can give propranolol first, and then give the heart failure or anti-ischemic beta blocker when the patient is discharged. So sometimes we use propranolol rin
Hmm,
for these patients.
Oo, pwede pala. Just a question on, because sometimes, for SVTs, which are probably more common than, than ventricular arrhythmias, and, if adenosine is not available, and if, for example, we can't give digoxin because there's renal failure, is it possible to give amiodarone for SVTs? I know, of
Okay,
course,
so yeah. So for SVTs, the guidelines actually do not mention intravenous amiodarone. Uh, the reasoning for this is it takes a while to to have an effect for especially for supraventricular tachyarrhythmias. I have patients who have come in for ventricular tachyarrhythmias sometimes, and they're given amiodarone, and usually they convert the next day. For 24 hours pa sila nabigyan ng amiodarone before they convert. So usually these are very stable patients na nagka-palpitations lang pero nag-VT, so they give amiodarone. For SV, supraventricular tachycardia, if you don't have adenosine, my second choice, actually parang pareho lang sila dun sa adenosine, would be IV verapamil. Okay, so if you can give IV verapamil, I think there's a problem with the supply of intravenous verapamil ngayon. I think I think I think we're going to talk to mga pharma to get intravenous verapamil back. So that's the one option. You can always do your vagal maneuvers, although the vagal maneuvers at best mga 40 to 50% success rate. And then adenosine is actually very good. Worst case scenario, if you do not have so amiodarone, yes, you can try it, pero the problem with amiodarone kasi it works on all the mechanisms of arrhythmia. So as a it puts us in a diagnostic dilemma. Kasi pag adenosine, if it terminates with adenosine, we know that an SVT is likely a re-entry SVT. So AV nodal re-entry or AV re-entry tachycardia. And usually hindi siya automatic. But amiodarone kasi works on everything. Although it is very, very slow. So medyo matagal before mag-terminate. I would actually just cardiovert the patient kung sa tingin ko matatagalan ako. So I wouldn't give amiodarone na. I would sedate the patient and then just give 50 joules ng synchronized shock while the patient sedated. Usually they terminate naman.
Okay. Now for as outpatient naman as continuing care for these patients, how long can amiodarone be taken safely?
So the problem with the side effects of amiodarone is they're sometimes dose related and sometimes related due to the length of time that you're taking the drug. So if you're taking more than 400 milligrams per day, 400 or more per day, and then you are taking it for more than 6 months, you have a high risk of developing the extracardiac side effects. So pulmonary toxicity, thyroid dysfunction. So usually it's binibigay namin yung amiodarone when we do our anti-arrhythmic review. Usually sinasabi namin, okay, itong patient na to is 86 years old. Okay na siguro yung amiodarone na to, parang for medyo for a few years kasi we know our life expectancy for 85 plus years old medyo mababa na and maraming competing risks, meaning they might get pneumonia or some other abnormality that will lead to their demise, hindi na yung anti-arrhythmic. So sometimes okay na magbigay ng amiodarone. But if you're looking at younger patients like 26-year-old patients, medyo mahirap na iyaan naman sila na you'll be taking this until you're 80 years old. Definitely the patient will develop some kind of extracardiac side effect along the way. And usually the development of these side effects will have you stop it. So most of the time we don't put the patients on lifetime amiodarone. You have to make a decision whether you can give another antiarrhythmic or do a procedure like radiofrequency ablation. For patients who are in heart failure kasi, they usually don't have, wala masyadong choice kasi if you have heart failure, that's structural heart disease, most of the antiarrhythmic drugs are actually very harmful. So amiodarone is the only one that you can give safely with patients with structural heart disease. So usually they're stuck with it for a long time, amiodarone, especially if they have repeated episodes of ventricular tachyarrhythmias. we try to limit the dose to mga less than 400 per day. So usually this will be in patients na taking 200 once a day. Those who have been taking 200 once a day, wala pa naman ako nakikitang like severe side effects. Usually transient thyroid abnormalities that go away once we lower the dose. Or I've never seen actually Blue Man syndrome. I think medyo mas prone yata yung mga Caucasians, or
Oo.
I think we have a tendency nga to underdose our patients nga kasi sa kanila 400, 600, 800 per day. Tayo kasi usually mga 200 per day lang yung mga nakikita ko sa outpatient. So I've never seen Blue Man syndrome really.
Okay. So this is not a forever drug, and in a way, it's a tiding over,
No,
a
it's not.
stopgap measure. And I mean, parang it's a bridge to a more definitive treatment in a way, no?
Yes,
Okay,
yes.
so I think Dr. Agbayani has answered all the queries, and so we would like to thank you once again, Dr. Agbayani. We are so grateful for your time and expertise, and we would like to present you with this certificate of appreciation from class of 1998.
Thank you for inviting me.
Class 1998 would also like to thank those who helped make this webinar possible: the University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and our sponsor for this webinar, DistiPhil. We invite all our viewers to join the next webinar on the prevention of invasive pneumococcal disease. Our expert speaker will be Dr. Marimel Pagkatipunan, a pediatric infectious disease specialist and clinical associate professor at the Department of Pediatrics of the UPPGH. The webinar will be held on the 8th of November, Wednesday, also at 12 noon. You can use the same Zoom link to register in advance or use the QR code shown here. And to receive your attendance certificate for this webinar, kindly answer the evaluation form, which you can access through the QR code shown on the screen. We will also post the URL in the chat box now. You will be able to receive your attendance certificate only after answering the evaluation form. So please ensure that the name you enter in the form is the name format that you want to appear in your certificate. So see you next time, everyone, as we continue to unlock knowledge for primary care workers and allied medical professionals. God bless everyone and stay safe always. Thank you.